Now I will go ahead and introduce Courtney Iwanicki and Stacey Fogarty-Brown, who are going to present the work that the dietitian group put together.
Oh, I gotta unmute myself. I'm going to share this on behalf of Stacey and I. All right. Can everyone see my screen? I think so. Okay. So thank you for the introduction, Kathy. I'm really excited to talk with you guys tonight. So Stacey and I are going to be talking about redefining CF nutrition in the setting of highly effective modulators. I did want to give a shout out to Ian, our adult dietitian. She helped Stacey and I put this presentation together, but she was just unable to speak with us tonight. So I first want to talk about this historic CF legacy diet. Nutrition has come a long way in cystic fibrosis, and I really just wanted to take a step back and kind of explain where these nutrition recommendations came from, why we always push extra calories, and why this is so important. So in 1988, a landmark paper was published. It associated a high-fat, high-calorie diet with an improvement in weight and survival. To us as dietitians, this was huge. So it was basically the importance of eating to gain weight, but really eating to live, eating to survive. And that is huge. That's why we always push so many calories and why it's so important, because it extended survival for individuals with CF. In 2002, the CF Foundation released official guidelines for a high calorie, high fat diet. And I think that the historic realm of this is what these pictures look like. Anything went, whatever we could get someone with CF to eat, whether it was fast food, ice cream, supplements, which we still use, that was what was recommended because weight gain was so important. While it is still really important, we still recommend a high calorie, high fat diet. Our thoughts behind this have changed a little bit, and Stacey will talk more about this throughout the presentation, but we're looking at a little bit like more heart healthy fats, that type of thing, instead of always turning to like ice cream or a cheeseburger. Next, I wanted to talk about the importance of BMI and CF. I am assuming everyone has heard about BMI. Some people are probably tired of hearing about BMI. Well, a higher BMI does correlate with better lung function. It's been proven. You can see these two charts here that show when BMI is above the 50th percentile, that lung function is better. And while these recommendations may not be as relevant in the setting of these highly effective modulators, it's still crucial to acknowledge how important these guidelines are for us as practitioners and for people with CF. These guidelines provide us with concrete recommendations backed by significant evidence that optimizing BMI is associated with better lung function. BMI definitely does have its limitations, though. It can be inaccurate if the height is not measured accurately, and it does not distinguish between fat and muscle mass. However, until there's more updated guidelines, which could be 5, 10, 15 years in the future, these are the recommendations we need to follow. However, as you'll see throughout this presentation, the nutritional landscape in CF is changing. And while we continue to monitor BMI, we want to change how we get there and what that BMI means for people with CF. We want to work with individuals and their families to promote intake of healthy fats and build muscle to achieve an optimum BMI. So overweight and obesity is increasing in CF. There's currently no agreed upon definition of overweight or obesity in CF in the United States because this is more of a new issue for us. It's not something that we've typically had to pay much attention to or deal with. The Australians have released some guidelines indicating for individuals 2 to 19 that the 85th to 95th percentile is considered overweight, greater than the 95th percentile is obese, and then for those 20 or older with a BMI of greater than 27 is overweight. I wanted to point out here that there is a limited benefit to lung function when the BMI gets to be above 25, which means so when someone's BMI gets to 25, the lung function isn't going to improve significantly after that time. The last thing on this slide that I really wanted to point out is the importance of body composition. There is a lot of research going into this. There's a lot of people interested in body composition because it's super important, and it might be another indicator than just BMI. And that's something that people are looking at. So individuals with CF often have a lower fat-free mass, and fat-free mass is primarily muscle and bone. So that means that they have lower muscle mass. And this lower fat-free mass is associated with a lower lung function and muscle weakness. So this is really where, our wonderful PTs come into play to encourage activity, exercise, to build muscle. It's where us as dietitians come into play to really promote an overall well-rounded diet, really trying to focus on building some muscle versus just increasing calories to build fat mass. I wanted to include this slide here just as a general overview of factors that can be associated with obesity. This is for all individuals, not just those with CF, but things like high blood pressure, cardiovascular disease, diabetes, fatty liver, depression, anxiety. These things increase as someone becomes obese. These are factors that someone might be more at risk for. And for my last slide, I just want to finish up talking here before I turn it over to Stacey, that, as we've kind of talked about, that nutritional landscape in CF is really changing. This really began with the approval of ivacaftor or Kalydeco in 2012. And this led to an improvement for a smaller number of individuals. However, in 2019, with the approval of Trikafta, nutrition needs changed very quickly. As you'll see on the next slide, Stacey shares Trikafta has been proven to improve weight gain and BMI. And while this is an important result of an amazing drug, some individuals are now having to change their lifestyle to prevent excess weight gain. And this is a different issue and problem than what people have faced in the past. So I just want to say that we're here for you guys, and I am going to turn it over to Stacey.
Thank you, Courtney. So this is our next slide. So we just kind of want to show this to show the participants tonight the differences between ivacaftor, that's going to be Kalydeco, and Trikafta. So we've seen a lot of changes, especially nutritional changes with these highly effective modulators. You can see in the middle column, that's Kalydeco, lots of different improvements in height, weight, BMI. But still to be determined for Trikafta. We do know that weight increases, we do know that BMI increases, but we're still studying and figuring out how overall Trikafta improves nutritional status. In addition to pulmonary impact of pulmonary function, these modulators also impact all of these areas of growth. So like we just wanted to show here, these can be true for many individuals, but however, it's not true for every individual. Not every individual with CF will see these effects on Kalydeco or Trikafta. So we wanted to make that point. While we do see some good responses and changes in nutrition, that we don't see it in everybody. 5% of individuals with CF do not qualify for a modulator, and some children and teenagers still struggle to grow whether they're on a modulator or not. So it's very individualized what the response is. So that very much will change how we tailor our nutrition advice. As we're tracking growth trends, as Courtney and I see our babies very often, really trying to watch and with our teenagers and see where we can get to their good spot, where they're doing well. So we just really wanted to point out that it's all very individualized. Like we see responses from these highly effective modulators, but it is very different for every patient. So where are we moving to the future with these highly effective modulators? So Courtney and I really like to take a balanced approach, and Ian in the adult world too. It's not just a one size fits all, eat all the calories like Courtney had mentioned, that legacy diet. We really want to look at balance. I think we all agree when we were making this presentation, we want to add, we don't want to take away. I was just talking about this the other day with a patient. I don't want to limit your diet. I want to see where I can add to it. How can we add heart healthy fats? How can we work that into your preferences? How can we promote proteins that a little bit more leaner, like chicken, nuts, legumes, seeds, dairy, things like that. How can we get more complex carbohydrates into your diet? These things will add fiber, help you keep you fuller longer, help control blood sugars. So overall, looking at balance, always trying to look at an individualized approach and always trying to work with each individual patient and family on their particular goals and where their lung function is the best and their growth is the best that it can be. So when we take these approaches, there's some new ideas out there. A big one that's kind of on fire and making the rounds is called intuitive eating. It kind of comes out of the eating disorder world, but it's really a good idea across many patient populations. Anybody who's struggling to identify their relationship with food, we want to help create a good relationship. There is a very big diet culture within our society, and so as dietitians, not only are we taking an individual approach, but we want to try and say, okay, how can we respect your body, your growth, your preferences, and how can we focus on, like I said, to add things and how you're feeling versus taking things away, restricting, saying you need to be on a diet and things like that. We want to really help you find ways to move, things that make you feel good, and always work with our families together. Mindful eating, another kind of term that's really hot right now, looking at the hunger scale, really checking in with your hunger. We've asked our patients, our individuals, for years to say, take an extra bite, just one more bite, eat past your fullness, get those extra calories in. So can we slow that down if we need to? Can we think about what we're eating? Can we check in on the hunger scale? Are we full? Are we good right now? Or do we need to eat a little bit more? And if we need to eat a little bit more, what could that look like? And just really honoring our needs and preferences. And honestly, really, we want to help our patients set realistic goals. It's not realistic to say, go lose 10 pounds next month. We don't want to do that. We want to set realistic, attainable, smart goals that we can help our patients, our individuals with, and really change strategies and habits over time. And really, overall, as dietitians, we really want to emphasize, say no to fad diets, say no to drastic weight loss. It is every diet 100% of the time fails. We know that. There's research behind that. That's why we want to add and build and improve versus take away and restrict. Unfortunately, in these pandemic times, eating disorders are on the rise. So we want to make sure we're helping our patients and our families create good relationships with their food, good relationships with their bodies, and all be on the same page as far as their nutrition overall. One thing we did really want to point out, and Courtney had mentioned this earlier, that we know BMI is not a perfect indicator. It doesn't tell us how healthy you are or unhealthy you are. It's not the sole determinant. And we want to point out that weight and BMI also are not solely determined based on what you eat. There's a lot of things that go into what your body size is, and that includes physiological components, pharmacological, the medications that you're on, your cultural background, your preferences, the foods you grew up on with your family, the environment that you're in, stress levels, exposures to toxins. We know these things can affect weight and BMI. Socioeconomic status. Do you have access to fresh fruits and vegetables? And this is where our wonderful social work colleagues can come in. If you're struggling to find these options, can we help you do that? Can we find a way to add these things in? What your income is, where you live. These are all play a role. So we absolutely 100% recognize that. Weight is not going to change just by what you're eating, but we certainly can help you meet your goals if you find that you are gaining excessively on a highly effective modulator. Can we help you? Can we help meet your goals? Because that can be a big change when you are on these medications. I think overall, the takeaway point from our presentation today is that things have changed. It's going to change. It's going to keep changing. And that's exciting, though. What we, preached 10, 15 years ago is not exactly what we're doing now. And we recognize that there is a shift and there's more research coming out. And we really want to take the time to work with our families to meet the goals and create a good relationship with food and bodies moving forward.